Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals, as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theatres with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We are in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
Happy Sunday morning to all. I am your host, Shoma Basu, Senior Deputy Editor with The Hindu, back with another edition of the Healthy India, Happy India initiative, which is a 15-part webinar series presented by Naruvi Hospitals, Vellore, and in association with The Hindu. In this 12th episode today, we will discuss MASLD, which expands to metabolic dysfunction associated steatotic liver disease, which is a silent liver disease linked to lifestyle. Doctors say that MASLD affects almost half our population, particularly the middle and older age groups in men. And it is an increasingly common yet often undiagnosed liver condition, which is driven by metabolic disorders such as obesity, type 2 diabetes, and insulin resistance. Our panelists today will explain in detail MASLD, and let me now quickly introduce them to you. Professor Ashok Chako is Senior Consultant and Head, Department of Gastroenterology and Liver Diseases at the Naruvi Hospitals. Prior to his present job, he was the head of Department of Gastrointestinal Sciences at Christian Medical College, Vellore, and Director, Institute of Gastroenterology, Madras Medical Mission, Chennai. Professor Chako has been the past president of Indian Society of Gastroenterology at the national level. He did his FRCP from London and Glasgow and FAMS and spent 2 years doing research at the Dunn Clinical Nutrition Centre, Cambridge, UK. Professor Chako has published close to 100 articles in peer-reviewed national and international journals. He will speak on MASLD, a silent epidemic, its prevalence as a global and Indian burden. Welcome, sir.
Thank you very much for the generous introduction. As you said, the topic I will speak today is MASLD, a liver disease linked to lifestyle. What I propose to do in the next 10 to 12 minutes is to answer 6 questions which are often asked by patients. The first is recently there has been a name change. This disease used to be called non-alcoholic fatty liver disease. And now there is a name change to metabolic dysfunction associated steatotic liver disease. So I will explain to you why this has happened. Also, what is the burden of MASLD? We have been told that it's a very common disease, and I will give you a few more points on global statistics. What happens to the disease over time? Most people nowadays go for a medical health check. And during the medical health check, there is also an ultrasound abdomen done. And there is an impression that comes out at the end of the test saying fatty liver. So they usually discuss with their peers or go to their local general physician and ask, what do we do? So they usually tell them, oh, everybody has got fatty liver. Don't bother. So we need to know, is it totally innocuous or not? Then, of course, the other question that comes up is, why did I get fatty liver? What causes fatty liver? Or what causes MASLD? Then are there any other diseases other than liver disease associated with MASLD? And finally, do people with normal BMI who are not fat, not overweight, do they develop MASLD? So let us try to answer these questions over the next 10 minutes. As I said earlier, this disease used to be called non-alcoholic fatty liver disease for many, many decades. But most liver specialists were not happy with this name.
Sir, can I interrupt you for a minute? I think your slides are not running. It's static on in your first slide, yeah. So you have to show it in the full screen mode, sir.
Full screen mode. Just go back. Can
you ask them? No, it is
get the full screen mode.
This is the full screen mode. You can ask. Ma'am, can you able to see the screen now?
Is this the full screen mode now?
No, I can't see your slides.
You just go back.
You have to do the screen sharing, sir, and then go on to the full screen mode.
Screen mode first.
Yes.
Now
sir.
can you see?
Yes, sir. Yes.
Okay, fine.
Thank you. Yeah.
Sorry about that. So I will go again through this slide. So it is just to tell that the disease name has been changed from non-alcoholic fatty liver disease to metabolic dysfunction associated steatotic liver disease. And essentially there are two major reasons why the name change occurred. The first reason was that NAFLD, or non-alcoholic fatty liver disease, gives no clue on the cause of the disease. But MASLD brings awareness that the important causative factors are metabolic factors. So that is one reason. The second reason was brought on by the patient community. They felt that alcohol and fatty in non-alcoholic fatty liver disease were stigmatizing for patients. For these two reasons, the specialists, after much discussion, decided to change the name, and that happened somewhere in 2022-23. Because of this name change, there was a mild change, or there was an addition to the criteria for diagnosis of this disease. When it was called non-alcoholic fatty liver disease, there were only two criteria for diagnosis. First, patients had to have a fatty liver on ultrasound abdomen, and the other causes, important causes of fatty liver, had to be excluded, like significant alcohol intake, viral hepatitis, and certain drugs. But with the name change, an additional criteria was added, and that is patients had to have at least one metabolic risk factor. And the metabolic risk factors are obesity or overweight, diabetes, high triglycerides, and high BP. Now, coming to the burden of MASLD globally, just concentrate on the pink areas, or not the pink, the red areas. They are the countries where there is a maximum number of MASLD. South America, Northern Africa, Arabia, and to a lesser extent, India and Australia. Now, to put numbers to this, the global burden of MASLD is around 30%. Or in other words, 30 out of every 100 people in the world have MASLD. What about India? The burden in India is higher. It's about close to 40%. And if you take the high-risk Indians who are overweight or have diabetes, it is even higher at 50%. So the bottom line is that the burden of disease in India, of this disease in India, is high. Another point to note is that in 1991, about 22, the global prevalence or burden was 22%. And 30 years later, in 2019, it is 37%. So there is a steep increase in the number of patients with MASLD, and the number keeps increasing. That is why we say that there is an epidemic of MASLD in India and a pandemic globally. What happens to the disease over time? Is it static or does it progress? The good news is that about 85% of people with MASLD have a static disease or even reversible disease. But unfortunately, 15% go on to develop inflammation of the liver called steatohepatitis, and about 5% develop cirrhosis of the liver, and a few people develop liver cancer. One might think that there's only 5% develop cirrhosis, but let us look at the actual numbers. Just look at the numbers on the left side of your screen. On calculation, it has been shown that there are about 56 crores of Indians with MASLD. 11 crores develop steatohepatitis or inflammation, and about 3 crores develop cirrhosis. So 3 crores is a large number. And that is why the most common cause of liver failure in the older age group is MASLD. And the most common indication for liver transplantation in the older age group is MASLD. Now look at the right side of your screen. This is to tell you some timelines of development of complications. How long does it take to progress from MASLD to steatohepatitis? Studies have shown it takes about 7 to 8 years. And from MASLD to cirrhosis, it takes around 25 years. So it is a slowly progressive disease. It is also a silent disease because there are hardly any symptoms. It is only when the liver fails that one realizes that one had this disease. Are there any risk factors that have an impact on disease progression? Yes, there are. The most common are the metabolic factors, and those with highest impact are diabetes and obesity, followed by hypertension and dyslipidemia. Please note that alcohol at any level consumption increases the risk of cirrhosis and liver cancer. So if one has a progressive fatty liver, definitely alcohol and smoking are out. There are certain genetic factors also which lead to an increase in risk of progressive liver disease. So what causes fatty liver or MASLD? We have said earlier that this is a lifestyle disease. And the two major trigger factors are a hypercaloric diet and decreased exercise. Or in other words, it is because of eating more than what you need and not exercising. This really is the state of most people these days. They eat more than what they need and they do not exercise. And that leads to overweight or obesity. A problem when you develop overweight or obesity is that you develop insulin resistance. That means you have adequate insulin in the body, but the insulin doesn't work. What is the function of insulin? One of the major functions is to prevent the breakdown of fat in fatty tissue. So if you have a resistant insulin, the fat breakdown in fatty tissue increases, leading to increased amount of free fatty acids in the blood. And these go to the liver, accumulate there, and are converted to a type of fat called triglyceride, which is stored in the liver, causing fatty liver. So once you have fatty liver or MASLD, there is fat in the liver and there are fatty acids that are liberated from them. Some of those fatty acids are toxic to the liver cell. They produce inflammation, and that is called MASH, that is steatohepatitis. And all healing from injury to the liver is by scarring or fibrosis. And when you have significant scarring of the liver, it is called cirrhosis. Are there any other diseases that are associated with MASLD? In addition to liver disease, in progressive MASLD, they have a higher risk of cardiac disease, chronic kidney disease, and obstructive sleep apnea. So if there is a progressive MASLD, one has to have a heart check and a kidney check. And finally, do people with normal BMI develop MASLD? This is another question that people who are fit ask. I'm fit, I don't have any problem, I don't have any symptom. However, when I took an ultrasound, they say fatty liver. Can I develop fatty liver? Yes, it is possible. And it is called lean MASLD. Why do the people with normal BMI develop MASLD? Because they also have a metabolic abnormality or a dysfunction. They also have increased fat around the belly, insulin resistance, and increased triglycerides. Lean MASLD is not a benign entity, should not be left alone. They also undergo steatohepatitis or inflammation and scarring or fibrosis. So they also need clinical assessment and monitoring similar to non-lean MASLD patients. So in conclusion, my dear friends, MASLD is a silent liver disease linked to lifestyle. There has recently been a name change of the disease from NAFLD, non-alcoholic fatty liver disease, to metabolic dysfunction associated steatotic liver disease. The number of patients with MASLD in India is high, around 40%, and increasing rapidly. So we say that there is an MASLD epidemic in India. MASLD is not a harmless problem that can be ignored. In 85% of patients, the disease is static or may be reversed. About 15% go on to develop steatohepatitis and 5% cirrhosis, and small numbers develop liver cancer. MASLD is a lifestyle disease, and the two important causes or triggers for MASLD are an increased intake of food and decreased exercise. This leads to overweight, insulin resistance, and fat accumulation in the liver. These patients with MASLD have an increased prevalence of cardiac disease, chronic kidney disease, and obstructive sleep apnea. Patients with normal BMI can also have MASLD, and it is called lean MASLD. Thank you very much.
Thank you, Professor Chapo, for that insight into MASLD. And we now move on to our next speaker, Dr. R.S. Arun, Head of Medical Gastroenterology at Madras Medical Mission, Chennai. Dr. Arun completed his graduation and super specialization in gastroenterology from CMC Vellore. He obtained additional training in interventional endoscopic ultrasound from USA, third space endoscopy from Spain, and did a program in practice management from IIM Ahmedabad. Dr. Arun has over 15 years of experience in gastroenterology as a clinician, researcher, and trainer. He has published several papers in national and international journals. His talk is on screening of MASLD, how to identify people with fatty liver, the various stages, and its surveillance. Welcome, Dr. Arun.
Thank you, Soma, and good morning, friends. In the next 10 minutes, what I would try to do is to help you find answers to some of the common doubts and concerns regarding uh, fatty liver, such as how does one find out if they have fatty liver, and how can we determine the risk of developing complications related to fatty liver, and what are the recommendations for follow-up of this condition once a diagnosis of fatty liver or MASLD has been made. So in this context, let me introduce some terms to you. So screening means to test somebody or examine him to find out if they have fatty liver. And once we find out if they have fatty liver, we need to identify their position in terms of the natural history of the disease. So if where is the position of the individual and how is he likely to progress as time goes. And finally, surveillance, which is a term for ongoing and systematic monitoring of fatty liver disease to detect early signs of disease progression and take appropriate steps for its control of progression. So now, how do we screen for presence of fatty liver? As Professor Chaco mentioned, it is a highly prevalent disease. Almost 40 to 50% of the population may have evidence of fatty liver. So we cannot test everyone for fatty liver, which is the mass screening model. So what we do is we do targeted screening of individuals who have a higher risk for developing fatty liver disease. So the preferred approach for screening for fatty liver is to look at the risk factors of fatty liver disease. So who is at risk of developing fatty liver disease or MASLD? Individuals who have diabetes mellitus or prediabetes, obesity, which is high body weight with respect to the patient's height, presence of cardiometabolic risk factors such as high blood pressure, high lipids, sedentary lifestyle, etc. There is a family history of liver cirrhosis or other lifestyle associated diseases such as the coronary artery disease, heart disease, stroke, etc. And finally, when we detect elevated liver enzymes during health checkup. So these are AST, ALT or SGOT, SGPT in the liver function test reports which you see. So how do we know who is likely to develop more complications, and how do we assess a patient whether he is in likelihood of developing complications more than others? So for this, we do something called staging or risk stratification with the purpose of identifying high risk of developing liver cirrhosis or liver-related malignancies. So to stratify this risk, we are guided by principles that fatty liver does not behave the same in every person who has it. So as mentioned in the previous talk, it is a subset of people who have this fatty liver who progress rapidly into complications. So we need to identify these people, and what we look for are liver inflammation or steatohepatitis, which is the driver of this liver fibrosis or scarring. And this liver fibrosis or scarring is the most important determinant of clinical outcomes. So we try to identify who has liver-related inflammation and who has evidence of liver scarring to determine who is at high risk of progressive disease. So the tools we use for this purpose include blood tests, which may be simple things like liver enzymes such as SGOT, SGPT, platelet count, bilirubin, prothrombin time, albumin, etc., or it can be more advanced serum markers. And what we do is we take these blood reports and calculate some scores to identify how much risk a person has to develop these complications. Another way by which we do risk stratification is by looking at the liver stiffness by imaging using a test called fibroscan. So now these are two examples of the scores derived from various parameters, various simple clinical parameters to determine the risk for progressive disease. So one such is NAFLD fibrosis score, where a score of more than 0.67 predicts liver fibrosis. So similarly, another score which takes into account age, the SGOT, SGPT values, and platelet counts, called FIBS4 score, shows a high risk of fibrosis if the score is above 3.25. So now, if another way of quantifying the liver fibrosis or scarring is to use fibroscan, which is a simple ultrasound based machine which looks at the reflected sound waves from the liver to determine its stiffness. So it's a simple, quick, painless and non-invasive test which is similar to ultrasound, and a value of more than 6 kilopascals suggests risk of fibrosis, and more than 12 kilopascals suggests cirrhosis. So with these two tests, we decide who deserves a closer watch. So these include patients where there are multiple cardiometabolic risk factors or features of metabolic syndrome, concomitant use of alcohol or drugs with liver toxicity, high FIB4 or NAFLD fibrosis scores, high fibroscan score, persistent elevation of liver enzymes, and ultrasound suggestive of advanced liver disease, which include changes in size, texture, etc. And these are the patients who should consider consulting a gastroenterologist or liver specialist for closer monitoring. So this is just to sum up the things I have said. So once fatty liver is detected, we rule out other causes, and we do non-invasive assessment of liver fibrosis using blood markers or fibroscan and classify them into low risk or high risk. And low risk is managed generally by physicians or family care doctors. And if they have a higher risk of disease progression, they require closer monitoring and more evaluation under the guidance of a gastroenterologist or liver specialist. So now, how do we do this surveillance, like looking out for complications in the high risk group? So this is by blood tests, ultrasound and fibroscan. Blood tests which are done commonly include liver function tests, serum alpha fetoproteins, and metabolic parameters like sugars and lipid profile where it is necessary. Blood and ultrasound study are repeated every 6 months to identify the progression of liver disease as well as to screen for development of liver related tumors. Fibroscan needs to be done once in every 1 to 3 years. However, we should remember that these surveillance are general recommendations and requires to be customized for every individual, because the progression of fatty liver in each individual is different. So to sum up, a person with diabetes, obesity, or cardiometabolic factor or abnormal liver enzymes detected during health checkups should be evaluated for fatty liver, and non-invasive tests such as blood evaluation as well as fibroscan is what we do to evaluate them. And once we classify them into low risk and high risk based on this evaluation, we decide how to do surveillance with blood tests, ultrasound, and fibroscan. And the care for low risk can be done by general physicians and family care physicians. patients who are likely to develop more complications faster are probably best managed by specialists for liver and gastroenterologists. Thank you for your patient listenings. And if there are questions, please may feel free to use the chat box to drop in your queries.
Thank you, Dr. Arun. And before I introduce our third and final speaker, I request the participants to start posting their questions in the Q&A box, which is now open. Dr. Rabindranath E. is a consultant in medical gastroenterology with Naruvi Hospitals, Vellore. He did his MD in internal medicine from PGI Chandigarh, DM in medical gastroenterology from Madras Medical College, and ESEGH from Royal College, UK. Professionally trained in ERCP, Dr. Rabindranath has expertise in hepatology, gut diseases, and GI interventional endoscopy. With more than 10 years of experience behind him in his field, he is also the Aslan Young Endoscopist Awardee of 2018 from Seoul, South Korea. Dr. Rabindranath has delivered multiple CME orations on gastroenterology topics and done many posters and oral presentations in national and international GI conferences. His presentation is on treatment of MASLD and how to prevent progression of the disease. Welcome, Dr. Rabindranath.
Thank you, madam. I will share my presentation.
Yes, sir.
Am I visible?
Yes, sir.
Yeah. Now we'll be speaking about the management of this disease, MASLD, SLD. So now with both my seniors talk, now you know about the elephant in the room that we cannot ignore. So we'll try how to get it out. So the outline of my talk will be like management. As it is a lifestyle disease, I'll be speaking more about the diet and lifestyle changes, and then will be the pharmacological therapy, that is the drug and injection if at all anything available, and bariatric surgery, and to monitor the progress and response to the treatment. The motto of my presentation is to make the liver brown again. Now you can see the gross section, that is the liver of a human liver of the fatty liver person and in a normal person. So our motto is to make it brown again. So the treatment starts with first things first, actually. So stop alcohol and smoking. Already your liver is having some metabolic dysfunction. You don't damage it more with added offense. So what amount of alcohol is allowed in MASLD? In any case, any patient who comes to me just ask this questions randomly, sir, what amount you will let me have my drink? I will say one answer, that is 0 ml. Don't torture your liver further. And then comes your control of risk factors, your management of metabolic comorbidities, that is your diabetes mellitus, your hypertension, your cholesterol levels has to be under control. If you see there is an equalizer in your audio video players, if you pull one button up, in this case of metabolic comorbidities, the other button will also come along with it. So if you decrease the risk of diabetes, your fatty liver, your MASLD condition is going to improve. Similarly, if you're going to improve your MASLD, your diabetes and dyslipidemia is going to improve. Both every other conditions of this metabolic comorbidities go hand in hand. That we should understand clearly. And the main point is in MASLD, the mortality, the death is more because of the cardiovascular diseases, that is heart attack, and not due to liver cirrhosis or its complications per se. So treatment of mainly depends upon the weight reduction. See, weight reduction, we always emphasize about the lifestyle intervention, because this is a silent disease and this is a lifestyle disease. It happened because of the lifestyle. So we have to revert it with the lifestyle only. So lifestyle intervention is by diet and exercise. And then comes the pharmacological interventions and bariatric surgeries and endoscopic bariatric therapy I will touch upon. So what really good thing in this disease is actually weight loss works. So when I see patients, one of my patients is 110 kgs. He used to ask me, sir, doctor, you are saying my ideal weight is 75 kgs. I'm 110 kgs. I'm never going to become 75 kgs. Why unnecessarily try? I used to say him, they don't want to get you to the 75 kg ideal weight. At least try and decrease your weight 10 kgs. If you're going to become 110 kgs to 100 kgs, you are doing good for your liver and your liver is going to thank you. That is the basic thing. What you have to understand is like we are not asking you to cut down your 30%, 40% weight. We are just asking even with your 3% weight loss, the liver steatosis, that fat deposition in your liver is going to start come down. With 5%, the inflammation is going to come down. With 7%, your blood numbers, AST, ALT is going to come down. And with 10%, your fibrosis is started to reverse. So what we ask is put your genuine efforts and start moving and start decreasing your weight. Even a kg, a 2 kg, 3 kg is beneficial for your liver. That you have to be have this in mind always. And the saying everything actually, problem is how many patients achieve this target of weight loss. If you say only 30% achieve 5% of weight loss and 18% achieve 7%, only 10% achieve in 1 year weight loss of 10%. So that is like it's very minimal because either the patient is motivated or they don't understand the concept of this weight loss being so important in their treatment. That we should understand weight loss is the primary goal of this treatment. So the target weight loss is 7 to 10% in overweight and obese patients. What for the lean patients? It is just even 3% weight loss is good for them. So weight reduction happens by diet and exercise. And I'll start with the exercise part. Exercise, what you have to do, we are not asking you to go to gym and do heavy exercises. We are asking you to do moderate intensity aerobic exercises like brisk walking, jogging, swimming, and cycling. How much intensity should be there? What is moderate intensity? Your heart rate should be increased up to 35% of your basal heart rate. That is, if it is an 85, it should become 100 plus. That is the basic requirement of your aerobic exercise, moderate intensity. And resistance exercise like weightlifting, mild weightlifting. That is advised in case patients who are immobile. They cannot move a lot, like morbid obesity, poor cardiorespiratory status, arthritis patients, etc. The basic thing is like you should do at least 30 to 45 minutes per day for at least 5 days per week. So exercise prescription, this is the most powerful treatment of MASLD known till now. The secret I've just given to you, not the tablets written by your doctor, it is your exercise prescription. So I'll give you the prescription again. It is at least 150 minutes per week, moderate intensity aerobic walk, brisk walking, jogging, swimming, and cycling. And typical effective patterns should be at least 3 to 5 sessions per week and 40 minutes each. So then comes the resistance training. That is like strength training that will be improve your muscle core strength. These are actually light weightlifting. You can use just 2 kg, 4 kg dumbbells also, but do it actually. Then squats, push-ups, and planks. And you have to do at least twice to thrice weekly at least. So why we are asking for muscle building in this case? We are not asking for the muscle building for any show off. Actually, there is something called a sarcopenic obesity, meaning your body is stout, but your muscles are thin. You're weak. It is not like if you're obese, you're strong. It is like your muscles are thin. So because of that, building muscle mass improves the insulin sensitivity and fights fatty liver. That is the concept. So if you can both do aerobic and resistance exercises, it's better. It pushes liver fat levels faster. And benefits of weight loss are independent. That is like if you do exercise, even if you are going to lose weight or not, already your liver is going to improve. That is, which means your liver fat falls even without clinically significant weight change, which means you continue to be active as much as possible. Weight loss is a bonus. So consistency is the key in exercise. Dropping below 2 hours of exercise a week wipes out much of the benefits. At least 12 weeks, which is the minimum duration to start reaping the benefits. So usually patient asks me, doctor, till when I have to follow this? Is there any 6 months, 1 year plan, something like that? I used to say, always make it a habit, make it enjoyable, and you'll automatically enjoy doing it once you see the benefits of it. The exercise prescription like high intensity training exercise, vigorous exercise, sprints, burpees, all help, but not mandatory. Don't break your bones, not required. Brisk but talkable exercise. That is like if you're going to walk or swim, you should be able to talk. Already delivers most of the benefit. So now comes to the next important topic, the diet in MASLD. This is both the cause and the cure. So once again, reiterating the same point, the principal point in diet is restrict your calorie intake. What I used to say to my patients whenever they ask me the diet, one line is cut down your diet by 30%. That is, if you're going to eat 3 rotis, make it 2 rotis. If you're going to eat 3 idlis, make it 2 idlis. That is the first basic step. You should cut at least 500 to 1000 kilocalorie of daily diet intake. As I already said, if you start decreasing your weight, actually even 3%, the liver is going to respond to you. So this is very important to say dramatically. Whenever you open your saturated fat containing chips packet, you are tearing part of your liver also. Just remember this picture when you're going to touch your chips packet next time. And then usually this slide I used to put in the alcohol related diseases, alcohol related liver disease and other diseases. It all begins in the same fashion. And this is because of the peer pressure, college mate, your office mate, your friends just wanted to start you just for fun. Like this cat playing with the snake's tail without any idea what harm it is going to bring. And then it falls prey for the bait. So now with the alcohol, I am extrapolating this to this processed foods. You have chips, your sugar added beverages, sodas, fries, midnight snack, trans fats, your fried rice, etc. So be careful on that. And how to go on the diet? Actually, your pointers are very simple. Choose low calorie diet. So you should be focused on a calorie restriction. It should be high protein, low carbohydrate diet. Increase the consumption of whole grains, plant-based proteins, fish, seafood, low fat or fat-free dairy, and liquid plant oils and deeply colored vegetables and fruits. And reduce the intake of red meat, particularly processed meats, and saturated and trans fats and ultra-processed foods, added sugars, and alcohol. So there are multiple patterns of diet you will be hearing. You follow this low fat, you go for the low carb diet, you go for this intermittent fasting, there is ketogenic diet, Mediterranean diet. Out of this Mediterranean diet is the only proven and efficiently proven for this MASLD. But in our Indian setup, it is highly impossible to break down so much of fat carb diet, and it is we don't ask them to do it for everybody except ketogenic diet. I will advise you can follow any of this in this. Ultimately, the point is message is to stick on a plan, whatever the patient is able to adhere to, and that results in weight loss that is desired. That is the best recommendation. Whatever you're comfortable causing your weight loss, do it. So once again, aiming for weight loss, what we have to do is decrease the calorie intake. So I'll say a max calculation right now. For decreasing 1 kg of weight loss, you have to decrease 9,000 calories deficient. That is like if you want to decrease 9,000 calorie, then you have to cut down 1,000 calorie per day. Then you're going to take 9 days to cut 1 kg of weight loss. This is simple mathematics. So the aim is to decrease at least half a kg. If I ask them to decrease 10 kgs in 6 months, they'll be afraid. I'd say drop half a kg this week, half a kg next week, they'll be happy. So that's the point. You just aim for decreasing at least half to 1 kg weight loss at least weekly. And the daily calorie intake for adults with MASLD most of the times is mostly 1200 to 1500 calorie that can be adjusted based on body mass. So how you can calculate this? You can calculate by the calorie calculator apps. You just write down whatever I had 2 idlis now, 2 rice. So just write down and calculate. That's a good habit. So adopt a hypocaloric diet. And you have to follow a nutrient dense diet, not calorie dense diet. For example, if 1 tablespoon of oil is equivalent to 1 plateful of cucumber, 1 cup of grapes, 1 idli, 1 roti without oil. So if you compare, this 1 spoon of oil is not going to give you satiety. Your appetite is not going to be fulfilled. But if you are going to have the rest of the options, what I said, you're going to feel full. So that is how we should choose nutrient dense diet, not the calorie dense diet. So diet, I've made some Indian perspective recommendations for our particular Indian population. So how to improve our diet? Actually, use whole grains and low glycemic index. Change to millets as much as possible. I'm not saying millets are very much less calorie. Millets are comparatively less tasty, and people used to consume lesser quantity, and that it helps in a better way actually. So millets like jowar, bajra, ragi used in rotis and khichdi or porridge, replacing your white rice. And use brown rice and red rice. You can use oats, but it is not the dictum. You have to take oats at all. You can use quinoa. You try to take whole wheat or multigrain rotis instead of using this refined flour of maida. And then comes vegetables. Vegetables, the simple basic point is not about the names. The name is like it should be non-starchy, it should be high fiber. That is more green, more fiber. Then if you avoid potato or aloo, that has actually high starch and less fiber, you can go for a alternative. You can go for raw banana that has high fiber and less starchy. So you have to replace with the non-starchy, high fiber vegetables. And some traditional Indian vegetables you can modify for your MASLD. You do your vegetable khichdi. You add vegetables in whatever you cook and increase the part of your fiber content in your food. That is the basic thing. Go light on oil, go more on vegetables, and whatever you do, your vegetable khichdi, sambar, rasam, it's good actually. It is having anti-inflammatory activity, but avoid excess oil. In your dalia broken wheat preparation, in your poha, you can use brown rice poha. In idli dosa, you can use for oats dosa, ragi dosa. Like that, you can change into millet based, except, avoiding your white rice based. And then comes plant-based proteins. Proteins are very good actually. You can increase your protein. As you say, Indians are protein deficient actually. So you can use all lentils, chickpeas, rajma, tofu, or paneer or sprouts. Actually, I used to say to my patients, in your lunchtime, whatever you are taking, your rice or roti, you cut short them. You just have only 1 cup of rice, and you should have 1.5 cup of sabji or puriyal, and you should have 1 cup of chickpeas. Your chana, any type of chana, or you can have 1 egg instead of that chana. That is, you should have more of fiber content and protein content, and cut short your rice content or your roti content, so that in your everyday lunch you should have all three. You should have a carbohydrate source, lesser carbohydrate source, your rice 1 cup, 1.5 cups of your vegetables, your puriyal or your sabji, or 1 cups of your protein source, that is your egg or your chicken or your chana varieties. And then fruits, once again, the fruits, it's not about the name of the fruits. You have to understand that the fruit should be having low fructose. If you have overly ripened banana, mango, jackfruits, those have high sugar levels. That is, once again, is going to act like sugars only. So less sugar levels, fruits like guava, pomegranate, apples, berries, papayas, amla. Amla is very rich in antioxidant. Those things you can substitute and you can use for your fruits. And beverages, I would prefer coffee, that is black coffee. And then you can go with buttermilks, you can go with herbal teas and coconut water, all good. When you're going to the dairy products, you just use low fat variant of the dairy products, which are to be avoided. As I already said, avoid maida, avoid white rice to an extent. I don't want to remove it from your diet, decrease the quantity. And high sugar foods like taking sweets, taking cakes, taking your fried samosa, vada, it's all banned. From my side, if you crave for the foods like that, you can go for a patty or a puff extra instead of your samosa. And avoid your mutton, pork, or processed meats, and avoid heavy gravies like butter chicken and kurma on a daily basis. I'm not saying completely stop, I'm saying avoid on a daily basis. And avoid your high salt food. This is a very big culprit in the Indian population. The pickles and puppets. These have more salt and these have more fluid retention. and causes more liver stress. These are all simple pointers. You will never know that your pickle is causing your liver damage. So use it wisely or stop using it. Alcohol, strictly no. So this is one of my society guideline chart. So I want to just put it here to emphasize two important points in this. One is the non-obese MASLD patients will also require 3 to 5% of reduction of weight, even within the normal BMI range, especially if the recent weight gain occurred or if abdominal obesity is present. This is one point. The second point, I have to say, is home cooked meals are preferable. Obviously, if you're going to cook at home, you're going to take the responsibility of the person who is going to eat. But in hotels, they're going to add 4 times whatever the masala ingredient or the oil ingredient because they want to attract you. They don't bother about your health at all. So home cooked meals are preferable. And the patients used to ask me, sir, then I should never take biryani, pizza, parota, noodles ever again in my life. I would say, yes, you can take, but you can take once a month in small portions. That too, if it is home cooked, but never to soda, alcoholic beverages, or processed food. Life hacks, what I would say is enjoy your favorite food. Take your biryani, but don't completely remove your from your diet, but take it in small portion, and you know how much is bad. So you cut short from there itself. The mantra is in moderation. And I would advise don't take it at the nights. After 7 o'clock, no heavy meal. And lessen the portion size and lessen the calorie intake, and that will lessen the liver and cardiac risk, and then it will increase your life. So coffee. So habitual coffee consumption, surprisingly, black coffee, unsweetened coffee, minimum 3 cups of day, 120 to 150 ml per day, helps in reversing your liver fibrosis. See, what you want to know is like it is not the milk added, thick milk added or thick 2, 3, 4 scoops of sugar added coffee. That is not coffee. That is I used to call as coffee payasam. Avoid it. You have to take black coffee. You should take at least last cup should be 6 to 8 hours before bedtime. Even decaf will do, any brand will do, instant will do, filter coffee will do, homegrown coffee do. Everything will go fine. Coffee works wonderfully in liver. I advocate for coffee. It has many benefits, and it reduces the risk of my part of metabolic diseases related liver disease. Also, there are multiple myths about the coffee. I just want to break it. It's not so dangerous if you are going to be having less than 400 milligram per day caffeine per day. So aim for weight loss. That is once again, I want to say again, how to aim for weight loss with the meal timing and frequency. You just don't take stomach full of food. That is not your stomach is required. It is not a tank you have to fill every time. It is not like a petrol tank you have to put in the morning. Then only the car is going to run for the next 4 5 hours. Not like that. No, you already have adequate storage in your body. You just have to have small meals daily with 2 to 3 grams and avoid eating within 3 hours of bedtime to optimize digestion and the satiety, and consider intermittent fasting or time restricted feeding to reduce liver fat. But evidence is emerging and should be personalized from person to person. So I will come on to a topic called as intermittent fasting. This is something that works. Something decreases your triglycerides, something decreases your liver fat, that improves your insulin sensitivity, improves your diabetes, improves your obesity. And how it is happening? There are 3 usual formats. One is like alternate day fasting. That is like patient will be having normal diet on day one, day two, they'll be taking very significantly hypocaloric diet, 500, 600 calories per day only. And then there is something called as 5:2 diet. That is like 2 non-consecutive days, they will be taking hypocaloric diet in a week. And there is time restricted the eating. That is what I advocate generally to the patients. What is time restricted feeding? I used to say that start with your 14:10 windows. That is like 14 hours you're going to do fasting and 10 hours you're going to eat. So it is not so bad as you hear it actually. If you start your first meal after 9 o'clock and finish your last meal before 7 o'clock, that is your eating 10 hours, that is your working time actually. So that is when you feel low when you are fasting. So eat food between that 9 p.m. to 7 p.m. and don't have anything between the 7 p.m. to 9 a.m. Okay, so if you are feeling hungry in this in between time, you can take hot water with lime juice drops, and you can take black coffee, black tea, herbal teas, etc. So if you are okay with 14:10, you can improve it to 16:18. That is like eating window between 8 a.m. to 4 p.m. or 9 a.m. to 5 p.m. That is up to you. But before starting this, always consult a doctor, especially those with advanced liver disease and other comorbidities, to ensure safety. So lifestyle modification for MASLD, as I already said, this is a lifestyle disease. So other supportive parameters also should be taken care. Ensure adequate sleep to support metabolic health and reduce insulin resistance. Address sleep disorders like obstructive sleep apnea, a risk factor for MASLD. Hydration. Guess what? Your best drink is water. Avoid your sugary sodas. Avoid juices. They lack fiber. Surprising alternative. Try chewing the fruits till you have a functioning teeth. So then comes the workplace interventions. For high risk like IT employees, implement workplace programs to promote physical activity. That is, you may have a small gaming area, gym area, workout area in your workplace itself. And healthy eating. That is like avoid, sodas and avoid fried items in your campus itself. That is all to be, that's a good workplace intervention I would suggest. The cultural context, change from your white rice and maida based rotis to multigrain options to millet based options and vegetables. That is good. So lifestyle modification for MASLD, now I'll be saying that sitting is the new smoking. Reduce your sedentary behavior, minimize your prolonged sitting, especially in Indian IT employees. It is said 85% employees are sedentaries. So what I do is, like, if I'm going to sit for 60 minutes, I'm going to stand or walk for 5 minutes at least. Don't sit more than 60 minutes at any place whenever possible. So incorporate non-exercise activity thermogenesis like standing or walking breaks during work. That really helps. So next comes to the pharmacotherapy. That is the drugs. If you see the chart, you can see that there are multiple n number of trials going on, because this is a big disease. This is a massive population. The pharma people are going to be interested. Science is going to be interested. The countries are going to be interested. But believe me, pharmacotherapy is only an adjunct therapy. That is, it is going to work with your diet and exercise only. There is no one magic tablet. Have this tablet, your MASLD is going to improve. No, it's not going to happen. Your exercise and diet is going to be helped with the drug in some cases, because if you see, there is a initial stage of this, as Dr. Arun already spoke. You can see there is no need for MASH therapy in initial stages of fibrosis, and it is the pharmacotherapy won't work. The tablets won't work if it is in a high state. There is only a limited window where you can use your tablets, drugs for the treatment. And once again, how many drugs are available? Approved drugs for FDA, that is in USA, that is only one drug, that is resmetirom. How many drugs it is approved in India? It is only one drug. By the DCGI, it is saroglitazar. There is no significant options. So believe me, none of the drugs that are recommended for weight loss in NAFLD and MASLD, that is tablets that are going to come in the market, just like semaglutide and the tirzepatide, etc., are not allowed to prescribe in NAFLD just for the sake of weight loss till now, as per the guidelines. For the obesity, yes, not for the NAFLD or MASLD part. So in India, whenever you are already a patient of MASLD, while you have visited your doctor would have written multiple number of drugs, UDCA, obeticholic acid, pioglitazone, everything have been taken out of the guidelines. Now it has been not recommended to use those drugs at all. And you now in India, the common drugs you are going to see in your prescriptions is either vitamin E, and the next second thing is cerebrotestat. In vitamin E, decreases ALT, it decreases inflammation, but there is no effect on fibrosis. So in why FDA has not approved this, because they required fibrosis decrease. Then it is not. The problem with this vitamin E is there is a risk of prostate cancer and hemorrhagic stroke. I personally don't use it often. And then comes the saroglitazar. Actually, it works. What in day-to-day practice we see it works, but the cost of the drug has to be considered, and still the further research is going on. That is why FDA has not given approval till now. It may get approval in future. So something about resmetirom. Resmetirom is a new drug, and resmetirom has.
Dr. Ravindran, how many more slides you have? Because we've already run past our allotted time,
Yeah,
and we also
yeah,
have a lot of questions.
yeah. We'll finish in
Sorry to
5 minutes.
interrupt you.
No problem. So once again, regarding resmetirom, it is not available in India. Maybe the patency ends next year. We might be getting this drug next year. Future drugs are semaglutide and lanfibranor. Then that we'll speak later. Regarding bariatrics, you should know about procedures to help people lose weight. There are multiple endoscopic methods and surgery methods. And believe me, no guidelines from our side has recommended bariatric surgery as a first line treatment, but you can use it for obesity. Indian Obesity Society says that if your BMI is more than 35 or if your BMI is more than 30, along with 2 or 3 cardiovascular comorbidities, then it is recommended to do bariatric surgery that will help your NASH or MASH also. There is a significant this thing problems for your caste, the preference access and the morbidity and mortality concerns, and it should not be done in your advanced liver disease called as decompensated cirrhosis. So how to monitor? It has to be regularly monitored. For low risk patients, you have to monitor every 1 to 2 years. In high risk patients, you just go to your liver specialist or a gastroenterologist. They are going to call you every 10 weeks or every 14 weeks or 20 weeks. You just stick on to your doctor. He is going to follow your liver. Don't give a break. Not visiting your doctor is going to damage your liver. So now this one I have wanted to introduce actually group counseling program that is similar to Alcohol Anonymous. Patients who are suffering from MASLD should make a group in your work environment, in your apartment space, so that you share your weight loss, you share your dietary changes, you share your success stories that will motivate the others. What I would prefer to say to my patients is like you adhere to a lifestyle modification. You write down your weight. What is your weight today? What is your weight next week? Write it in a paper. It's old school method. It really works because you see your benefit in your paper. You feel more motivated, and you should regularly assess for your BMI and waist circumferences. And as I already said, you should decrease your cardiometabolic other comorbidities treatment is important. One more point important in our setup is like pediatric MASLD. That is a growing concern. The liver disease has started occurring in patients with 7 years, 5 years also. So you should monitor the growth parameters, liver enzymes, ultrasound liver, and fibroscan annually with a focus on sustaining lifestyle changes in your children. So now speaking everything about this, so we now know this is a ticking MASLD bomb. Defense is important. Act wisely and defuse the ticking MASLD bomb. How would you do that? Once again, weight loss, healthy diet, regular exercise, at least 150 minutes, managing comorbidities, avoid alcohol and toxins completely. Now, one last appeal from my side. Shortcuts are always longer and also dangerous. Avoid alternative medicine or holistic medicine or magic potions or guaranteed healing assuring quacks or pure or secret herbal supplements. Believe me, they are doing more harm than benefit. So conclusions, first steps, look for it. It's a pan-metabolic disease workup. If you have diabetes, if you have hypertension, go check up, do an ultrasound, fibroscan, look whether for you have the disease or not, MASLD or not. Educate, it is a pandemic. It is a silent pandemic. It is bigger than corona, but nobody speaks. It is a silent pandemic. Modify the modifiable risk factors, treat to prevent progression, follow to monitor progression, get motivated, move on, decrease your weight. Thank you.
Thank you, Dr. Rabindranath. We've already really crossed past our time. I'll quickly take a few questions. Professor Chako, you did mention about the change in name of the disease was perhaps to broaden the understanding of the disease. But what about the common population? As you mentioned, that 50% of Indians, could be affected by MSLD. So, like Mr. Arvind Rao wants to know what exactly are those symptoms that we should look out for whether I have any liver problem, and what is the early stage of, like when should I go for a test? Or when earliest recommended age, or how will you explain? So you have to unmute yourself.
The sad thing is that this is a silent disease. There are hardly any symptoms until the liver fails. There are one or two symptoms that people may get. One is fatigue and tiredness, and the other is a mild discomfort on the right side of the abdomen. There are no other symptoms. So you cannot predict from symptoms that I have to go for a checkup. But what I would suggest is the people who should go for a checkup are those who are overweight or obese, those who have diabetic, those who have blood pressure, and those who have their triglycerides are high or HDL low. So these are the metabolic risk factors. Anybody with a metabolic risk factor must have a checkup of the liver. Second is what age? I think anybody above 40, 45 years of age, especially males, should at least have an ultrasound after 45 years.
What about children? Because children also are pretty obese. I mean, this obesity is increasing in children population. And so
Yes.
do they also stand the risk?
Yes, they can also get MASLD, the obese children, the overweight children. And the mantra is really to reduce weight.
Mhm.
So it is not only necessary to do an ultrasound and say you have fatty liver, because ultimately even the treatment for fatty liver or obesity and other metabolic problems is a weight reduction. So that is the bottom line, weight reduction.
Dr. Arun, would you like to take this? Is there any effect of stress and anger patterns that can cause cortisol spikes on liver health?
So there are no direct relationship with that, but stress can influence our dietary intake and contribute to sedentary lifestyle, etc. So stress by its effect on lifestyle has an impact on fatty liver.
So Sonia is also asking that does liver health cause direct issues on kidneys as well, or vice versa?
Yeah, once they develop a liver cirrhosis, then it will start involving other organs also. So until then, a liver is able to compensate for the damage due to fatty liver. But once the liver scarring is so much that cirrhosis has developed, then other organs also bear the brunt of disease.
Dr. Rabindranath, you of course focused a lot on diet and exercise. So somebody wants to know whether chemical soaps and shampoo and hair dyes that we use, does that also affect the liver in any way?
See, in case of fatty liver, there are multiple causes for fatty liver. As we know, alcohol, some toxins, some aldehydes used in this soaps can cause fatty liver, but they are not going to consume basically. Just applying over your skin, etc., is not going to cause your fatty liver problem. But some toxins are known to cause fatty liver, but those things don't come under the topic of metabolic associated dysfunction related fatty liver. Those are a different type of fatty liver. Even some drugs, something like methotrexate, they use for rheumatoid arthritis, will cause fibrosis of the liver. So that is not the part of this MASLD. But yes, some chemicals can cause fatty liver.
So do pregnant women, I mean, because there's this thing about women do gain weight after childbirth. So are they at a high risk of getting fatty liver, Dr. Chaku?
Yes, anybody who increases weight has a risk of fatty liver, because when you increase weight, there is something called the insulin resistance that happen. which leads to a fatty liver. So anybody who increases weight, maybe a pregnant lady, it may be a person who is sedentary, anybody can develop fatty liver.
And is there a way to prevent it altogether?
Yes, the prevention is again to make sure that you don't gain weight. Fatty liver, you diet and exercise. Make sure you
So,
don't gain weight, or after delivery, slowly go on to a diet and exercise program after delivery. And because usually what happens is after delivery, they're very busy. They have to look after the baby and other jobs they have. So they ignore the exercise, and also they eat more. So ultimately they gain weight, and that can lead to a fatty liver. Yes.
so as you were also mentioning, Dr. Arun, when we were having a backroom discussion, I think you mentioned that there's a lot of either neglect or ignorance or panic. It could be either when somebody is told about, having a fatty liver. So, I mean, is there a situation where a person has comorbidities and who cannot do regular or the exercises that are often recommended? So I mean, how do those people, I mean, who have other comorbidities, how do they kind of, uh, take care of the liver?
Mainly, people have joint issues or musculoskeletal problems which prevent them from doing weight bearing exercises. That is like walking, running. That may be very difficult for people with very high weights and weak joints. However, they can consider static cycling. They can try swimming. There are other means of exercises which can be done in such cases. So those lifestyle trainers can suggest alternatives to these. And in addition to that, uh, we need to incorporate the dietary changes also. That will assume more importance when there is a limitation to what a person can do by physical activity alone.
So it is safe to say that fatty liver is not really life threatening. And if people follow this diet and exercise regime, it is reversible.
Yeah,
Yeah,
until they develop significant scarring of this liver, this fibrosis is an event which where it becomes irreversible. So lesser the fibrosis, if we don't allow the liver to develop fibrosis, then we have won half the battle. So the key to preventing complication is to prevent scarring of liver by diet and lifestyle measures.
Dr. Rabindranath, what is the role of supplements, especially milk thistle and vitamin 12, to prevent and management of fatty liver disease along with lifestyle change?
Not directly related. See, in India, they are going to this incorporate B12 deficiency, D deficiencies in every other disease. That is not directly anywhere studied. Even the milk thistle, there are multiple supplements. Silimarin. I don't want to name these supplements. The famous green color daba, everybody will be carrying. Those things are not going to help. The only thing that has been proven to benefit is your exercise and your weight reduction and your diet. Avoid your soda, don't add sugar, no white sugar, brown sugar, any colored sugar. And avoid your late night snack, no food after 8, 8:30. That is the best thing. Your milk thistle and your vitamin B12 correction may help you in other ways, not in your liver disease.
Since you mentioned green tea in your talk, so there are lots of questions on drinking tea, what kind, milk tea, what about milkshakes that we give to children regularly? So, I mean, then also somebody is asking about dry fruits, consumption of dry fruits, whether that needs to be moderated.
See, ultimately, whatever the calorie intake, whatever the requirement, one person who is sedentary, just sitting and doing a desk job, he requires only 1,200 calories per day. If you're going to have milkshake, two milkshake, three milkshakes, you're going to get 1,200 calories. So I won't recommend milkshakes for anybody. adult or anybody. Those things are added. You just turn the back and see how much sugar it is added. Don't go for a soda. Every bottle has too much of sugar in it. Don't go for a milkshake. If you want to give milk, you can give. In children, whole milk is preferred, not a problem. In adults, those who have already documented MASLD go for skimmed milk. That is better. And regarding your dry fruits are good in many ways. It has good fiber, but in moderation because they are calorie dense food. If you're going to take too much of those dry fruits, those are going to harm. That is what, like, you're going to take one handful of groundnuts, that is good. If you're going to have more than that, actually it is going to have high calorie. It has good fiber, good fat, everything. But just 100 grams, it's going to give 570 calories. It's very easy to take 100 grams easily. So you have to remember, you just check the calorie of whatever you have. If you are so much aware of the calorie, or you just open a calorie calculator app. It is widely, there is something called as mypal.com, this thing app. Just go put the calorie check and make sure you just, whatever you take, that should be less than what is the calorie requirement for your day. Avoid milkshakes in children, that I don't agree. Avoid sweets, avoid milkshake, avoid deep fried chips.
Dr. Chako, there's a question for you from Atul Kumar, who wants to know the role of pancreatin in fatty liver. And also, does constipation is any kind of sign of having fatty liver?
Pancreatin has no role in fatty liver. So no, that is out. Second, what about constipation? There is a theory, and borne out by studies, that if you take a Mediterranean diet, there is an improvement in fatty liver. And the reason for that is there is a change in the bacteria of the gut. Favorable bacteria come in and help liver health. People with constipation have unfavorable bacteria. So there is a possibility that if you are constipated, it is not good for a fatty liver. There is no good data on it about constipation, but having good bacteria in the gut, taking lots of fiber, vegetables, fruits, like a Mediterranean diet, helps to improve fatty liver.
Right. So there are a lot of repetitive questions, and people are again asking too many questions on diet and what kind of exercises. People are citing their specific problems about their age and weight. And I'm skipping all that because we have to really kind of close the program. So I would like to thank the doctors for so patiently explaining everything about MASLD. I am sure the audience has benefited learning about how to take care of their liver. And thank you, participants, for having all those pertinent questions coming in. Today's webinar on the silent liver disease linked to lifestyle was presented by Naruvi Hospitals, Vellore, in association with The Hindu under Happy India, Healthy India initiative to inspire and promote well-being. Thank you all once again.
Thank you very much.
Thank you.